Good afternoon and welcome to our presentation about decision-making in partnership with patients during the COVID-19 entitled Getting It Right, Improved Patient-Partner Decision-Making Guidance. I will be your moderator. I'm making this presentation from my office in Ottawa, which is the traditional unceded territory of the Algonquin Anishinaabe people. We recognize and deeply appreciate their historic connection to this place and the opportunity to gather here today. We rarely have an opportunity to improve as we go when we are implementing new practices or policies. Today our discussion will be about experiences and improvements in Quebec's experience. In April 2020, Quebec had to contemplate the possibility of an extreme shortage of space, equipment, and staff in intensive care because of the pandemic. As a preventive measure, a government working group was created made up of over 45 representatives of various health systems as well as a panel of patients, and quickly published a triage protocol related to the allocation of intensive care resources. In light of the continuing evolution of scientific knowledge and the concerns expressed by a number of organizations working with vulnerable clienteles, the protocol was updated in the summer. So our panelists will be discussing the lessons learned through the patient participation approach in rethinking the protocol in order to take into account the priorities of patients, families, and caregivers. So here our panelist, Vincent Dumais, is a co-director of the Center of Excellence on Partnerships with Patients and the Public at the Faculty of Medicine of Université de Montréal. As this is part of the research center of the University of Montreal Hospital Center. Marie-Ève Boutillier is responsible for the Ethics Center in the Quality Evaluation, Performance, and Ethics branch in the CIS de Laval. Joseph Dahin is an intensive care specialist at Cité de la Santé de Laval, and Ghislaine Rouly is a patient partner at the CEPPP, the center that is co-directed by Vincent Dumais. So these are our speakers that will be part of the panel today. So let me ask them our first question. Marie-Ève Boutillier, can you describe why this protocol, can you describe the history of the development of this protocol? Why was it put together? What is the history? What was the prototype? And why was it put together? Thank you. Over to you. Hello. So just to bring you back to last March. Last March was the very beginning of the pandemic. So the government of Quebec was getting organized to respond on an urgent basis to this worldwide pandemic. So within the Ministry of Health in Quebec, we created a clinical steering committee for COVID-19. And the committee decided, among other projects, to create an ethics committee and to produce a triage protocol to face a potential shortage of intensive care spaces. In other words, at that time we feared that demand for intensive care beds would be so high that we would not have enough beds, enough respirators, enough resources in intensive care to meet demand. So in this emergent situation, a small group set to work thinking about how we could produce protocol to allocate intensive care resources in the context of a pandemic. I say a small group, but the small group became a big group. We brought together about 45 people, once again, in an atmosphere of urgency to produce this triage protocol. We contacted people who were working on this kind of protocol in other provinces in Canada, especially in Ontario. Ontario had were a step ahead of us at that point. And so we drew lessons from work that had been done elsewhere, in Ontario and elsewhere. So our group was able to put together a triage protocol in about 5 days. This was a tour de force. Among the 45 people who were mobilized to prepare this triage protocol. There were clinicians, there were palliative care physicians, intensive care physicians, emergency room physicians. We also had psychologists, we had jurists, ethicists, and we also brought together a second panel of patient partners. So the patient partners contributed to that process. Remember, this all happened over 5 days, so we were able to develop and submit to the ministry a triage protocol that would guide choices if the demand for intensive care beds became larger than the resources. We can increase the capacity of intensive care, as you know, but at some point you're going to reach a saturation point. So you also asked what guided the development of the protocol. Without getting into too much detail at this point, what we wanted with this protocol is to maximize the benefits. So we wanted to avoid as many deaths as possible, to save as many lives as possible, but also we wanted to be fair. So we wanted to maintain a degree of fairness. We wanted the people to be treated as equitably as possible. We wanted the criteria to be standardized as much as possible so that people be entitled to the same treatment once they get to the point where they need intensive care. What do I mean by the same treatment? I don't mean the same treatment as intensive care, but the same evaluation based on their clinical condition. What we were trying to do was to allocate respirators if we didn't have enough and the demand was high, so allocate respirators to people who had the best chance of survival. In other words, those who had the best prognosis. So that is roughly the way the protocol works. I won't go into detail. I assume that we can get into it later. Thank you very much. So the next question is Ruli. You participated as a patient partner in this process. So can you describe your role and the importance of taking part in developing such a protocol? Yes, of course. So first of all, I would like to explain how it worked. Vincent Dumais had called upon 3 solid patients who were used to participating in this kind of exercise with a lot of experience, including in this specific topic, who would be able to analyze the document from an ethics point of view. And I think that was an important feature. So in addition to Vincent's constant support, we were told that we could have asked to be supported by a broader community of patient partners. We're a group of patient partners, expert patient partners, I might say, who work together. And that group meets regularly, or rather the panel of 3 patient partners met several times during that period to advance our discussion. So these weren't new topics for us. The document actually looked pretty familiar. Based on our experience with the health system, we were able to draw on real-life knowledge, on our experience, and that is an extremely rich source of input for developing such a standard. So we relied on our experience on concrete things that we had experienced. All 3 of us, unfortunately, been to emergency, been to intensive care many times, and we still have trauma and side effects from those experiences. So we felt that was a really important document. Being immunosuppressed, triage is especially important to me. It was very important that we make sure that patients who would be involved in the process be aware of what was happening. There's another dimension. I receive a lot from the health system, and I wanted to give input from an ethical, from a moral, human point of view in those decisions that are extremely difficult for personnel and for families. I felt it was a civic duty. So that's what I would say to start. Thank you very much. So the protocol was published in the spring of 2020 and led to a lot of reactions from the health system, from the media, from the population. Vincent Dumais, can you tell us about how the protocol was adapted following the first publication? Yes. So the April context, well, was an emergency context. We were in panic mode, I should say, worldwide, including in Quebec. So the protocol was developed in less than a week. So the process was to say, okay, I had joined the ethics committee as a patient partner originally, and I worked with Ghislaine on various portions of the document as it evolved. We didn't have time to have a broader consultation. We really focused on patient partners. And I think the role of patient partners at the time was very important to make sure that the document have a level of acceptability. It was very important to have a perspective of how will this be perceived by the population. A document like that can be very good, but if it's worded in a way that shocks or raises hackles in it, it will be hard to implement it. So when it came out, it took some weeks actually to get some reaction. And the very first reaction was to say, okay, let's start a revision process, but this time let's bring in patient associations that had spoken to the media, had responded in the media. A lot of the revisions had to do with wording, if I might, but not just editing. I'm talking about words that would enlighten clinicians on interpreting the criteria. So we worked with Marie-Ève, with her team, and with patient associations to start a dialogue. So there was a certain tension. The emotions were running high, and it was understandable. But we started working at two levels, which were very close, actually, and interconnected. And this was a really complementary process between advocacy groups and patient partners, and it was a really process of co-designing. So the patient partners were working from inside, whereas advocacy groups were providing input, if you like, from the outside. So we worked hard to bring the two together, to bridge the two perspectives, and that second process took a number of weeks, and the outcome was a document that I believe was a consensus between most stakeholders, and this was a complication. This is really how a design process works. It had to remain a clinically effective document while respecting the perspectives of patients and patient representatives. So this was a really complex exercise that requires a true spirit of co-building, co-designing, and that's what happened over the weeks that followed the revision of the protocol. Thank you, Vincent. Dr. Dain, you are an intensive care physician. Can you talk to us about your experience working with this protocol and the process? Well, the good news is that we haven't used the protocol. We haven't yet had to use it, and we hope it stays like that. We hope that we've worked for nothing and that we'll have enough resources to take care of everyone. But as an intensive care physician with an academic interest in resource allocation, this was a great opportunity to work with the group, because the values that that animate me are, of course, informed by what I've seen during my training and in my practice, namely the possibility of inequities in accessing intensive care. What do I mean by that? Well, when science and data are brought to bear on intensive care resource allocation, you realize that there are a lot of things, such as physicians' prognoses or decisions to allocate resource or not, are essentially subjective, maybe because, say, a physician had a good or bad experience with a certain prognosis. So for two identical patients, two different physicians could make different decisions. So it was important for me that that protocol equalize chances of access for all patients. The important thing was that we wouldn't be wondering what was the right or wrong decision, but that we could make the same decision for all patients, and that this process be built with continuing input by patients from the start, from the outset. This was something that we wanted to do for patients, and we wanted patients to feel that their interests had been represented, so that they would truly believe that they would have an equitable opportunity to have access to intensive care, regardless of whether where they sought to access the services in Quebec. So Marie-Ève Boutillier, in terms of the protocol, Dr. Dane said that it hasn't been used, but when would it actually come to be used? Well, that was actually a question that we expanded on in the revised version. So if there is ever saturation of the system, that is to say 150% capacity, institutions have to prepare to prioritize. And when we reach 200% capacity, that is when the prioritization process kicks in. But it's important to say that upstream of that, every effort is made to transfer patients, to increase capacity, etc. So we really have to remember that this kind of protocol is last resort. But as I said, we did anticipate that there could be a time where it had to kick in. Thank you. So Vincent Dumais, I see there's a question in the chat box. During this process, was the existence of unconscious bias and ableism in healthcare, especially as it pertains to healthcare allocation? Yes. And that's one facet of the complexity of the exercise. We can't ignore those biases, and we want to actually bring them out and discuss them. And that was an interesting part of the exercise at the two stages. There was a lot of discussion, a lot of dialogue. There were a lot of things that were surfaced through a reflective approach, where we were able to see our own biases reflected in other members of the group. So to reach that level of trust, the group has to be able to reflect on biases. That applies to professionals, that applies to patients as well, because we patients had biases. For example, sometimes our biases were different from those of professionals, sometimes the same. So the best way to prevent unconscious bias was bringing them out and discussing them and working together, working them out. And of course, the framework for the ethical for this ethical reflection is really important. So there's a theoretical, conceptual framework that we can build on. There's a lot that has been done in this field already, and that was very important to help us discuss constructively the various criteria. And what's interesting in an ethical discussion about that patients are part of is that it's not hermetic. It's not exclusive. You don't need to be an ethics expert to take part in a discussion of ethics. Marie-Ève did an amazing job as facilitator for the process. If we have a high-level ethicist who leads the discussion and who does an excellent job introducing topics and formulating questions in a way that is as intelligible for everyone, then citizens, patients who don't necessarily have an ethics background, as well as professionals as well, because most clinicians that we worked with didn't necessarily have an ethics background either, but it was easy to approach ethical discussions, and that is why ethics will remain a major area of partnership and co-design. Dr. Daniel, would you like to add something? This is such a crucial issue that I think it's worth dwelling on this a little bit. To talk about our experience in doing simulations. Marie-Ève led a team where we simulated the use of the protocol with a group of clinicians. And what we realized was that whether conscious or not, but the human the human desire to find some way, some factor that can discriminate between two patients who are otherwise identical is very strong. So, oh, well, he's not compliant with his medication, or in the simulation, the clinicians were looking for something, anything, to decide to whom the last respirator should be given. So that was very enlightening. So how did we try to reduce that bias? Okay, there are three aspects. Number one, almost all the criteria that we're using in our form are evidence-based. So we did a literature review to identify all the criteria that are used for access to intensive care. Number two, those criteria are focused on the short-term mortality prognosis. So we're not judging quality of life, functioning, or even post-intensive care functioning. And finally, number three, as Marie-Ève said, the process is such that the clinician who fills the form after the evaluation is double-checked by a second clinician, and then there is a group of three, a triage group of three clinicians that take all the forms together and makes a decision. So there's multiple layers to try and eliminate the chance that a bias that was present at the first evaluation persists at every stage, so that resource allocation be as free as bias as possible. Justine Rouly, would you like to add to the discussion about bias? I believe you're on mute. Yes, we can hear you now. So what fascinated me was to see the way everyone was working together in mutual respect, but also authentically. We were able to say things that were sometimes uncomfortable, especially in front of colleagues or fellow patients, but it was a very humanly authentic process. Those were human beings trying to find the fairest solution possible, and that was one of the most significant things about the process, emotionally significant. So it was something that was really exceptional. Maria Boutillier? Well, maybe what I would say is, okay, I agree with almost all of the other panelists' comments, and for me, that whole process, leading that whole process, was a revelation to me of my own vision of ethics, as clinicians, as ethicists, we're always at a crossroads. We have to avoid the temptation of choosing a path. So if you're at the crossroads, you can see all of the positions and try and bring them together, and bring people together, get people talking. And I think the best tool is the relationships, as Vincent Dumais said, with the patient groups at the beginning, with the advocacy groups. We felt there was a certain tension. They had concerns, and the first thing we did was to listen to them, create a link, a bond. And once that bond was established, then we were able to make huge progress. Same thing with the clinicians, because as ethicists, we're parachuted in this area, and there's an imposter syndrome. We're talking to leading specialists, but creating this bond of trust allowed us to make progress there again. As Ghislaine Goury was saying, it was based on authenticity, and that's what enabled us to go as far as we did and to have the product that we have today. So I'm very thankful for everyone who did choose to get into the relationship building process. Okay, so the next question. First of all, Dr. Dahin, so why was there not such a protocol before? Okay, there was the pandemic, but resource scarcity isn't a new thing. Why now? I think there are a number of factors. I think that first and foremost, it's a very sensitive issue in a public health system like ours. One of the fundamental principles is that everyone has access to resources at all time. And now you're developing a protocol saying, well, actually some people won't have access to certain resources. That's really superficially, it seems like an affront to Canadian and Quebec values. So that's from the point of view of the public. And from the medical point of view, well, the principle of autonomy that physicians have in terms of their treatment decisions. So we always say that clinicians are supposed to be patient advocates and society advocates. So, but in their daily lives, clinicians are much more often in the role of patient advocates. So if all of a sudden you tell them, well, for reasons related to social good, you will have to not give access to resources to some of your patients, well, you're taking away some of that autonomy. So that could be a reason for reluctance, clinicians' reluctance to accept that they would give up some of their full control over decision making. Thank you. So we have some comments in the chat box about the bias, and we appreciate those comments. Thank you. There are lingering concerns within the system, and especially people who have rare diseases. So what does the protocol have to say about that? So let's start with Vincent Dumais. Okay, so, well, that was where the difficulty lay. Also, people with disabilities are mentioned in the chat box. Okay, I have a rare disease, and there were two of us actually, two rare disease patients, and we're very sensitive to exceptional situations. So that's where a protocol, and so you have to strike a balance between clarity of criteria, but also a margin, leaving a margin of maneuver to blend in those exceptional cases. You can't turn the triage criteria into a checklist, a dogmatic checklist, you're in or you're out. You have to have create enough space, enough of a margin to be able to take on board those exceptional cases in the reflection process, or to make sure that they could be taken on board. And that, to me, that's the difference, the big difference between the first version and the second version of the protocol. The first version of the protocol did that, but I think there was still work to do to expand that. The second version of the protocol allowed a space, thanks to the wording that was used, the phrasing that was used, made room for situations where specific cases that didn't match the criteria or that could be subject to interpretation, we made sure that to a greater extent that they would not be that would not fall through the cracks. So, and there are clinical, very concrete clinical questions, and there are also what the choice of word injects as an orientation or an approach. So we worked, I think, on those two levels, and more so in the second version because we had more time to do that. So that would be my initial answer. I'm sure my other co-panelists will have more to say. Yes, so let's go around. Ms. Boutillier? Okay, maybe what I can add is that this balance between standardized criteria, very clear criteria, and we were able to improve on that in the second version, but also leave room for clinical judgment. That was a real balancing act, and it was I think an important addition to allow physicians to input clinical information to have more relevant decisions. So we made that more explicit in the second version. Dr. Dain? No, I don't have much to add, except to say that we explicitly added at the end of the form a reference to the Quebec Charter of Rights and Freedoms, where everything that is related to discrimination based on disabilities, as well as sexual orientation, age, etc., it's all in there. So on a number, in a number of places in the protocol and in the form, there are reminders to clinicians, to the reader, that discrimination based only on disability would not be an acceptable basis for a clinical decision. Thank you. And so I'll ask our next question to Marie-Ève Boutillier to start with. So there's a suggestion in the chat box that a more formal process be used, maybe for future versions of the process. Yes, this is a citizens jury. Okay, well, I don't want to do a spoiler, but I have a student at the University of Ottawa who is looking at that democratic deliberation, not necessarily exactly a citizen jury, but it's something that has a lot of potential, and we're thinking about that to see how we can have greater input from citizens, patients, stakeholders. So yes, it's something that that is very important to pursue because we have a worldwide pandemic, but there'll be others, there'll be other crises. So the more we can refine our tools, the better we'll be prepared. You're on mute. Okay, sorry, I was on mute. Okay. So what I wanted to add was that specifically on this point, it's not that there's not a will, it's that we don't know exactly how that can work in such a context. It's a very complex question. When we're talking about, we always circle back to the same issue, the issue of representativeness. So when we bring in patient partners or patient associations, the representativeness is a given, and you know, on what basis they're talking. They're talking on the basis of their experience, and that's why we ask for their input, just like clinicians. Patient associations have a very clear agenda, and those patient advocacy groups who had input had already taken positions on this kind of triage, not in a specific context, but in general, so they already had well thought out positions. But citizens in general, that's more complicated, and you have to be careful. You have to be able to to be able to work on a serious, on a solid basis, because we're looking for answers in a very, very important context. We have to make sure that we don't end up in a mechanism where we have to dilute a document that has to be clinically effective. How do you orchestrate a citizen consultation process? What basis of representativity are you going to start with? So those are complex issues, and at this point there aren't necessarily clear answers. So yes, in principle, but we really have to think and experiment, think about this experiment, and I'm sure that that's what will happen over the next weeks and months. Ghislaine Roulier, I'll ask you the next question related to the dynamics in the discussions in the first and second stage. Often there are perceived power imbalances between patient partners and health professionals or institutions that are developing a framework. What was the atmosphere? How did it feel to take part in those discussions? Can you hear me? Yes, okay. So as far as the atmosphere, I found my place. I have to say that in any case, I'm told I'm not an easy person. So if I'm asked to take part in a process, I will find my place in the sun. But on both occasions on which I worked with Vincent at ministry meetings, I was able to say what I had to say. I felt I was a full participant. Overall, it depends. There are processes like this where we had full input, but in other cases, we're seen as intruders or people who don't really know what they're talking about. So I would say, unfortunately, there is still a degree of paternalism here and there. But in this particular case, in this particular process, I didn't feel that at all. I felt I was in my place. I felt I was listened to. I was able to say what I had to say. I was able to get changes made to the end product together with the team. So it was a rigorous atmosphere, not easy. It wasn't. Those weren't easy conversations we were having, but we were listened to. Thank you. Dr. Dane, would you like to add something from a point of view of a health professional? Well, not much. I might just, I might add, I don't know how this type of thing works in other provinces, but it's more and more something that is sought for. At least my organization, the Suisse de Laval, we even have a patient partnership office. So we're really, there's a real legitimacy for patient partners within the organization. Now, is there still work to be done with some of my colleagues, regardless of their profession, to, first of all, let them know that patient partners exist and what their role is? Yes, of course there is. But I'm reassured to know that in the at the top of the organization, the tone at the top, this is a legitimate context. It's encouraged. It's brought forward in all the institutional decisions. So that's where we're at. And we are we're going to have a co-patient safety chief who is a patient. So that's how we chose to apply that in our organizations. The principles are universal, but and we applied those principles in our protocol. So I think we can be proud of that. Vincent Dumais, the next question: is there a diversity lens when the group was brought together, especially the patient partners, in terms of representing the population in general? Okay, I'll get to that, but I just want to add something first. One of the important parts of the process to create this atmosphere it was again the tone at the top. The assistant deputy minister for patient services was on board, Marie-Ève. So we're a group that's used to working together for many of us. So hence the importance and here it's not so much a conflict of interest, but having continuity in partnerships, because when you work in partnership routinely in a health institution or a research network, when you have to focus on more difficult questions, well, you start out with a relationship that's more mature and that helps you face crisis dynamics like that. But there's a kind of continuity there, because what's very important is that in order to get to that level of relationship maturity, you can't do partnerships on an ad hoc basis. You reach for a patient when you need them, and then you forget about them for weeks. Why we started out so well was because we were in a continuum of engagement, and that started at the top. And having a deputy minister and assistant deputy minister that give their blessing, that it won't make the process work, but it has to be there for the process to work. So in terms of diversity, no, it's not something that we had an opportunity. We think about it all the time. We are reflecting about the representativeness of our network of patient partners in general, but in the context of the time, it was not something that was applied. So this may also be a difference. If I might make a small political comment, this might be a difference between Quebec and other provinces. I might say, unfortunately, it's there, but we still have work to do. I'm very aware of that. We have a lot of work to do in the systems we've put in place and the networks we've created, and we're working on it, but it's not always obvious. So we're engaged with it. We're thinking about it, but in this specific framework, to be honest, we haven't had an opportunity to reflect on that. Generally speaking, not just in terms of patients, patient partner, but generally speaking, there was a degree of representativeness, but not sufficient in my own view. Marie-Ève Boutillier, would you like to add something before I ask you the next question? Well, maybe when I was given that mandate, I was told, okay, I need the science and I need the patients. So that's where we started. And in terms of diversity, in terms of time, so the first version was put together in 5 days. So engagement was proportional to the time we had. So the patient panel during the first wave, it was one thing. The second wave, we went much broader. We didn't have just 3 patients like in the first version. We brought in patients associations, patient advocacy groups, and I think in a future third phase with research projects, we can go much further in bringing in a diversity of viewpoints. But that will be for phase 3. Okay, so let's continue on the theme of diversity. A question that's related to more complex pediatric cases, and generally speaking, how do you take into account the diversity in terms of that particular population? In Quebec, okay, we have two protocols. We have an adult protocol, and from the beginning of this session, we're talking about the adult protocol, but we also have a pediatric protocol. The objective is slightly different in the context of COVID, because as we know, COVID mostly affects older people, so children are more spared by COVID, and children have dedicated health resources, and as we know, children must be protected. So the idea of the pediatric protocol is to see how we can, on the one hand, allocate to them the resources that are dedicated to them while protecting protecting them. So it works differently than the adult protocol. The way we worked for the pediatric protocol, obviously we invited, in the same way as we did for the adult protocol, we invited pediatric specialists, so we had pediatricians, neonatologists, and we also invited parents. We invited patients who work in centers for children with major disabilities. So this protocol was also updated during the summer, alongside the adult protocol, and so we were able to get input from associations and so on at the time. So that's the development process that we followed for the pediatric protocol, which doesn't have quite the same goal as the adult protocol. We want to defend the interests of the children while trying to see how we can how we can make sure that they're allocated the resources that are earmarked for them. Okay, so Vincent Dumais, the next question: are you aware of other provinces or other jurisdictions that have brought in patient partners and developed such a protocol? No, not to my knowledge, but I don't claim to know everything that's happening in Canada. I'm well informed, but not fully necessarily, not comprehensively. But just to reassure you, quote unquote, I think this was an exceptional situation everywhere in the world. There were a lot of groups that started this kind of process in Europe. In France, for example, I know that in Belgium, patient partners and associations did try to have input, but there wasn't really a lot of partnership. So I think in terms of patient engagement during COVID, worldwide the situation is not that bright. So I think that this process here has been an exception, which doesn't prove the rule. So in terms of patient partner engagement, even in Quebec, in a lot of the other processes that happened, here at the Center of Excellence, we were asked to contribute, but a lot of patient partner processes were just brought to a grinding halt by the crisis. So when the crisis happened, patient partners were just cut out of the process with no thought given to whether they were adding value to the process. Whereas on so many occasions, it had been shown that we did add value. So it's kind of it's like a glass ceiling. What made a difference here was that there was already a team in place. There were already trust relationships. There was a relationship of openness. And there were people with very strong humanist perspectives for whom it was obvious that patients should be involved, and who started from the assumption that patient partners brought value, and value that was that had to be part of the process. And I think there are a lot of lessons to be drawn from this process for future experiences throughout the system. Thank you. So the next question for Dr. Dahin, and after that for Ghislaine Ouili. So the question is, the evaluation seems to be entirely medical, clinical. So there are other groups who are part of the discussion. You said you had several stages. Are there other stakeholders like the family, social workers? So who's part of the group, or why is it entirely clinical? Excellent question, Melissa. And even the palliative approach. Actually, thanks for giving me an opportunity to bring that up. So the first step in the assessment of each patient involves discussion with the patient and family when the patient can't have a discussion. So we're talking about prioritization criteria, but before that, it's the inclusion criteria. So in the inclusion criteria, the objective of care is crucial, and the physician doesn't decide that. The last thing we want to do is heroic, deliver heroic treatment to a patient or family that don't want it. So that approach is from the outset, and that involves explaining the potential subsequent steps. And it's a challenge during COVID, given restrictions in terms of visits, but it's essential for us that be the first step. So it isn't entirely clinical at that point. But after that, yeah, we did ask ourselves, how far can we bring families into the decision-making process, especially, for example, in terms of palliative care discussions. And the answer that the committee formulated in the end is that COVID is a special beast that doesn't allow us to reach the standard that we would like to attain with family involvement. If we're talking about elective surgery where you have time to make those discussions, yes, we would. But here we're talking about making a decision to intubate a patient in respiratory distress or not. And those are okay. Imagine in an extreme pandemic context where people are lined up at the door and they all need ventilators at the same time. Well, unfortunately, we don't have the luxury of time to have those discussions, to have an informed discussion. And the palliative approach, we also discuss that because there are patients who might already be intubated in intensive care, those who would be taken off mechanical ventilation that might lead to death. So in those cases, yes, indeed, a palliative approach would be best, but it's hard to impose the same approach in all centers across Quebec, knowing that if there's a pandemic, there's no pandemics don't strike in all regions, and not all resources are not the same elsewhere. We're talking about big university centers with lots of specialists, but the little country hospital will have the same issues, the little rural hospital. So in the end, we said, okay, so physicians, nurses, intensive care teams are already multidisciplinary. They are already concerned to make sure that families are brought in when we're clearly in an end-of-life situation. So the message in the protocol is, well, don't abandon a patient when they're no longer receiving intensive care. So the palliative approach is there. There's no compromise. Now, the center could decide to get a palliative care involved early, in parallel with the intensive care team. That has a favorable impact on the family participation, and some experiments have been done to that end, but we can't impose that. So we would hope ultimately that the multidisciplinary values reflect the values of the group that put the protocol together, namely co-design and putting patients and families at the heart of decisions. Okay, so let's give our panelists an opportunity to have the last word. So Ghislaine Rouly, over to you. Well, I don't have much to add after Dr. Dahin. We have to think of the situation. This is a crisis situation. This is an emergent situation. As Dr. Dane said, you don't have time to go further. But of course, if possible, we're going to talk to the patient. If it's not possible, talk to the family. So it's not done from an solely medical point of view. Yes, there's a whole clinical side, but there's also the whole human aspect. And I think even if there are no other stakeholders like social workers and so on, you're in an emergent context. But despite that, the humanity is there. I've seen it. I've experienced it with my own daughter, with myself. So what I would say is, what I'm saying is what I've seen. There may be exceptions, but let's not get into that. Vincent Dumais? Okay. Maybe one thing about during our first, the work on the first version of the document, there was a specific portion about end-of-life accompaniment, and that part was written by the patient partner panel and then submitted to the committee that used it practically word for word. So I think that was one of the major areas of input of the patient partner panel. And in fact, right now, the Ministry of Health seems to be taking an interest in the document, and especially in this portion of the document. But we'll see if they bring in patient partners or not and how they're going to use it now. Marie-Ève put the ball in their court, but we'll see if they catch it. Marie-Ève Boutillier? Yes, so I was going to say that our patient partners have remained very humble so far, but they actually wrote a major chunk of the protocol. And also, there was some significant input from the so-called psychosocial professionals. In other words, how do you take care of people when you're implementing such a protocol? And the triage team will have to make very difficult decisions. The clinicians will be in a very difficult place. The families will be in a difficult place. So we tried to see how we could support everybody in this process, and that is part of the protocol, the need to take into account of the more maybe emotional aspects or the emotions related to what you're experiencing on an ethical level. Okay, so we have 2 minutes, so I would give you 30 seconds each to tell us what you took from the process. I suppose that it's still evolving. Ghislaine Rouly? Okay. I'm sorry, I didn't hear the question. I'll pass my turn. Okay, so Dr. Dain. In 30 seconds, well, what I take away from this is, well, I think Marie-Ève's leadership and her ability to mobilize, to engage, to take that mandate that is huge and to bring the right people around the table and to deliver a document that's very, very high quality. That's the kind of leadership that I wish on all organizations and all institutions to bring patient partnership forward. Vincent Dumais, what did you take from the process? I totally endorse what Joseph has just said. Marie-Ève did a remarkable job. That was a very intense process, and you need leadership like that to make things move forward. Otherwise, it doesn't. And then what I take away is the clear demonstration that patient partners are key levers for problem solving even in an intense crisis situation, and I hope that lesson won't be forgotten. Maria Boutillier? Well, what I take away is collaboration from everyone in this project. It's the kind of thing that we have to do around the table to bring in lots of positions, lots of points of views, and I'm very happy with the outcome of the process. And so you need the science and the patients. And Ghislaine Rouly, you have the ultimate word there. Well, I take away a lot of pride from this. It was a team that worked together with respect and dignity and with exceptional leadership, like everybody else has said. So I think, as all the others have said, yes, you need exceptional leadership, and also you need to bring us in as well. I think patient partners need to be there at every stage. So thank you very much. So thanks to all of our participants and our panelists. This concludes our session. Good afternoon.